Hi, this is E. David Crawford. Joining me in this presentation is Dr. Brian Moran, who is a radiation oncologist, an international expert in the area, and head of the Chicago Prostate Center. Brian has really championed the team approach to the management of prostate cancer, the multidisciplinary care. He has put together a great program involving the radiation oncologist and urologist and to benefit patients. And it benefits both sides, both the radiation oncologist and the urologist in the care of this. And as I mentioned, more importantly, the patient. So Brian's going to share with us really that's sort of a lifelong piece of work he's been doing at his Chicago Prostate Center, not only with brachytherapy, but with focal therapy. Focal therapy is something everybody's talking about right now, but Brian has been doing this for decades, and he's going to share with us some of his experience with focal therapy and management of prostate cancer. Brian, welcome, and thanks for taking the time to do this.
Well, hello, Dave, and thank you for the invitation to give this presentation. So I am in Chicago, and we have been doing brachytherapy for close to 25, 30 years. And this presentation will be confined to the past 20-year experience at Chicago Prostate Center. So to go forward, I think it's important to understand that the whole management of prostate cancer has dramatically evolved over the past 10 years, and that is largely in part to recent advances in technology, both our diagnostic abilities, including MRI, more sophisticated ultrasound, and obviously the genomic profiling that is going on now. So we're actually in a new era, and when we look at how would I describe this? I need to advance this slide. When we look at the traditional risk groups of prostate cancer, we're considered low, intermediate, and high-risk groups. And I think that because of the new developments with improved diagnostics, we're really dealing with a spectrum disease today. No two prostate cancer patients are identical, and yet we seem to treat them all identically. So if you look on this slide, I call this the prostate cancer spectrum. You have low risk, low volume disease on the left-hand side, and it goes all the way, say, to high risk, high volume disease on the right-hand side. And obviously, as you go through the numbers 1 through 6, these are much more aggressive cancers to the right. Now, it's also important today because of the aging population and also the baby boomers coming onto the scene that obviously age should be considered, comorbidities, and quality of life issues are paramount. When we look at brachytherapy, obviously we have to have a strong concept of the patient's individual urodynamics for patient selection. So,
hey, Brian, I'm going to interrupt you 1 second.
Sure.
We'll just edit this out. There is a pointer that's over on the left-hand side that you can pick up. I think it's one up from the bottom, a little dot pointer, and it's really effective to use that if you can pick it up.
Okay. Let's see. I think I see it, right? Is it laser pointer? Yeah, there we go. Okay, so that one, Dave. Okay, that is very helpful.
So just go ahead and start this slide again.
So in Chicago, we began our experience in October of 1997. Since that time, we've treated over 20,000 or close to 20,000 patients have been consulted. We've performed 18,219 procedures. 80% of these were low-dose rate prostate implants using various isotopes, iodine, palladium, and cesium. And the 20% of patients underwent the stereotactic transperineal prostate mapping biopsy. The average age of our patients in the last year was 67 years old, ranging anywhere from 41 to 85 years old. Percentage of patients less than 50 years old is 0.5%, 50 to 64, and this number is rising because of the baby boomers. 38.6%. Every year this number goes up in our database. And 65% of the patients were 60, median age is 60%. Overall risk groups, the majority obviously were low-risk patients, 47.9%, 39% intermediate, and this is the D'Amico staging risk group and selection criteria. And then high-risk patients, 12.6%. After 5 years, there's been a relative plateau, and these are the numbers that we're still seeing now at 20 years, although I don't have that published yet. Basically 95, 85, 75% for low, intermediate, and high-risk groups, respectively. This is an interesting slide showing that in 1997 there was a dramatic rise in the number of implants that we were performing here in Chicago, and then right around 2007, 2008, we experienced this sharp decline in numbers. And this was largely in part to our referral base, which, because IMRT came on the scene, along with some other robotic surgery, and I think that the patients were just not being referred for brachytherapy. But this currently, in 2017, we plateaued, and we're actually starting on the rise again. I can explain my thoughts on that. This is a very interesting how we got to the point of using these transperineal mapping biopsies. Back in 2004, the idea came up of using the template. Whitmore and a few others had experienced some experience using template-guided perineal biopsies. And we started doing this using general anesthesia, identical setup to a low-dose rate brachytherapy implant. And we divided the prostate into 8 octants, of which I'll show you schematically in a minute. The important thing is this entire cohort had all had a prior negative transrectal biopsy, at least one prior negative, yet they all had persistently rising PSAs. So we identified this group of patients as kind of a diagnostic dilemma for the urologist. We went ahead, we did the biopsies using the template through the perineum, and we identified malignancy in 40% of these patients who were previously thought not to have the malignancy. The biopsies tended to be more positive in the apex of the gland rather than the base, and that was statistically significant, as well as the anterior apex. And this is the thought here is that the template-guided biopsy allows one to comprehensively sample the prostate, especially anterior apex. And the reason for that is because with a transrectal biopsy, it can be more difficult to make that angle to get to the anterior apex. So this is a schematic view looking at a sagittal view of the prostate. There's the prostate, seminal vesicles, and these are the axial views. So what we did was we identified 8 octants, one which would be the right base, left base is Roman numeral 2, and this would be right base posterior, left base posterior, and these are the anterior ones. And again, this would be the apex. So you have apex here, base here, and when we did a biopsy anteriorly, and then we could only obtain one sample, one core from the apex, we identified that as a hole. So that is how the biopsies are obtained. They are recorded. Each specimen is recorded. For instance, this would be big C 1.0, and then that information is given to the pathologist as well. And what we found was that in that large group of patients, we were taking probably one core per 1.2 cc's of tissue, and that was just, the doctor who's performing the biopsy was instructed to comprehensively sample the prostate, usually with 5 millimeter spacing. So this biopsy technique is very comprehensive. It's a mapping technique. It's very objective. It doesn't lend itself to subjectivity. This is fascinating. The E. coli sepsis rate and sepsis just in general is 0. We just have not seen that. It's relatively painless. Patients do not complain. They don't require post-op pain meds. And it gives me as a radiation oncologist a great level of confidence in assessing tumor burden. And not only that, but mapping, which will allow for a much more sophisticated implant. And by that I mean, if the disease is confined to one area of the prostate, we were able to put more radiation in the malignant portion of the prostate and spare more of the normal gland, which is going to lead us into this concept of focal therapy. So those implants were what we call dose-painted implants. Now, back in 2004, cesium, which is not a new isotope, but it came back to the marketplace, caught my interest. And cesium is an isotope that has a very short half-life of 9 days, and it has a generous energy of about 30 kV compared to iodine or palladium. The patient risk groups that we treated with cesium were 60% low risk, 32% intermediate, and 8% high risk. We followed these patients for up to 10 years, and what we found was that we had an excellent control rate, and it was only 8% failures. And we are publishing right now a randomized study looking at iodine versus cesium, the results of which I can tell you were really equal. So there was really no difference. This is the overall disease-free survival, 92% at 5 years and 84% at 10 years. So again, breaking it down on the outcomes for risk group, you can see that the low-risk patients did well at 94%, 5-year 87% for intermediate, and 80% for high-risk groups. 10-year BNED, you could say 89%, 70% for the intermediate risk, and 64% for the high-risk group. So we were pleased with the results using this isotope. Now, moving on to, that was our whole ablative gland experience that I just presented to you. Now, this concept of focal therapy arose more than 10 years ago in our practice, and we've been doing it more than 10 years, but like anything else, it's continued to evolve, not only with the technique we use, but also patient selection. So let's just walk through. Conceptually, focal therapy, theoretically, it definitely makes sense, especially for patients with low volume, low risk disease. And one could argue that, is it a compromise between watchful waiting or active surveillance versus radical prostatectomy or whole gland ablative therapy? And I do think it is, and that's what I'm going to show you here. Primary goal of focal therapy, obviously we want to eradicate the malignancy, but hopefully in doing that we'll create less morbidity than we would if we treated the whole prostate. Clearly there's a lower cost. In our experience, we use isotopes, and the amount of isotopes is dramatically less because we're treating 50% or less of the prostate parenchyma. One of the interesting things when you really think about it is this is a unique therapy in that it has incredible salvage options. The salvage options would include IMRT, radical prostatectomy, because the volume is so small that you should not encounter problems with prostatectomy, although as I'll tell you, we really haven't had the need to do that. The very interesting concept, patients are asking for this. And I think that a practice needs to be open to it, provided there are good guidelines for patient selection. And Hashim Ahmed and Peter Carroll, Mark Emberton put this little book out, which is really a nice book to read. It's very logical. It covers the spectrum of the published data with various modalities, whether it's cryotherapy or HIFU or brachytherapy. Although I will say that the brachytherapy experience in focal therapy is behind the times, and we need to get some more work done with brachytherapy. So I'd like to think of this as a revolution. It's not for everybody, but what's allowed us to go forward is the precise location of knowing where the tumor is within the prostate and directing our target therapy to that location. So revolution, as Dr. Emberton pointed out, is transition from not knowing where the tumor is to knowing where the tumor is. And patients will often remark, well, doctor, if the cancer is only this one area, why do we have to treat the whole prostate gland? So there's a variety of options to identify dominant lesions. Clearly, MRI has become very popular, and this shows the dominant index lesion very nicely on a multiparametric MRI. But there's conflicting data in the literature today showing us that oftentimes the DIL might not, once it's biopsied, might not be a malignancy at all, and it is not uncommon in our experience to find in patients who've had negative MRIs significant disease. And so I think there's going to be some more controversy if one solely relies on MRI, and that's why I think tissue is key. So we believe that in comprehensive biopsy, using a template through the perineum should be considered for any focal patient to have confidence that you're dealing with the low volume, regardless of the risk group, low volume disease. So this is the struggle. How do we assess our success? How do we evaluate our success rates? And really, we have to rely on PSA. PSA responses, as I'll show you, have been highly variable. They have, and I think this is going to be demonstrated as more time goes on, they're going to be volume dependent, meaning if we implant half the prostate, what we're starting to see is that there's approximately at least a 50% reduction in the baseline PSA. And then, of course, the problem is we don't have an agreed upon standard for success as we do with traditional brachytherapy, where the standard would be the Phoenix and nadir plus 2 ng per ml. Paul Nagayan suggested possibly a PSA velocity of greater than 0.75 ng ml per year. So, my hope is to really analyze our data further, as I'm going to show you, and try to make some conclusions. So we embarked on a prospective study looking at focal therapy using the isotope Cesium-131. And again, I'll review Cesium as an isotope very similar to the other seeds on the market. However, the half-life is 9 days. The reason I chose Cesium for this study, I figured that I would be compromising my target volume to begin with, going ahead with a focal procedure, and I chose it because it had the most generous energy and would be the least likely isotope that could be prone to cold spots within the target volume. So from April of 2015 to January of this year, we treated 52 patients. Our objectives were to obviously evaluate PSA response, but I think more importantly, the rate of PSA kinetics is going to be the thing to watch. Quality of life has been very encouraging. These patients have essentially no side effects whatsoever in the majority of them. And then some of these patients underwent mapping biopsy versus transrectal biopsy, and we wanted to see what the difference would be there. Gary Onek published years ago on his focal experience using cryotherapy, and he found that the patients who had the perineal biopsies had a much lower recurrence rate than the patients who had a transrectal biopsy. And I think that makes sense just because of the confidence of knowing the gland was thoroughly biopsied. Moving on, the dose of radiation to our target volume is 115 gray. And then the breakdown of the patients, 25% of these patients had a transperineal prostate mapping biopsy, whereas 75% had the traditional 12-core extended sextant biopsy. Risk groups were as follows: low-risk patients, 57%, intermediate risk patients were 40%, and we even treated 2% of the patients that were high risk. So this is an interesting concept. One would argue that focal therapy is only for low-risk, low-volume disease. I think that as time goes on, we are going to be entertaining more aggressive cancers, provided our confidence level is high that we know exactly where the disease is. And this is the breakdown of the patients with the pretreatment volumes, right around a median of 51 cubic centimeters. And that's the other benefit of focal therapy is if you have a patient who has a large prostate with poor urodynamics, you can offer them focal therapy if they're appropriate candidates based on their pathology. And you can see here, this is the volume, the treated volume is 17.8 median. So it looks like about maybe a third to just a little less. And then prostate volume treated the percentage is about 33%. So in these 52 patients, we actually treated 33% median of the prostate. Pretreatment PSA median was 6.4 with a range of 0.2 to 23.3. So this is the breakdown of the patients we treated. This is the early PSA outcomes. As you can see, there's kind of a stable trend. Some of these are a little bit stable or downward, and as we go out farther, the question is, what can occur in the remaining untreated prostate? It is very capable of producing PSA. So my thought is, as long as we can create a downward trend, and hopefully that would be it, but if not a stable trend, that would be ideal. And so, if you look here, the next slide right here, this would be the PSA kinetics in the patients treated with 25 to 50%. And this is the downward trend I was speaking of. So clearly it's effective therapy. The question is going to be really optimal patient selection. So factors that affect patients' choice of treatment, obviously the cure rates, bladder and bowel toxicity. Toxicity is a very critical component regardless of which treatment modality we offer, whether it's surgery or external beam modalities such as proton or IMRT. Sexual function, these patients are getting younger and younger, and this is very clear that that's important. Time off work, I never really considered this until I found patients coming in saying to me that they needed to be back at work as soon as possible, or they lived a great distance from facilities that would offer treatment. Say, to go 9 weeks for radiation might be difficult for somebody in a rural community. Cost as well, focal therapy is without question the most favorable. So who are candidates in my opinion? I think low risk, low volume, intermediate risk, low volume, high risk, low volume. These are the patients that I would entertain focal therapy treatment. What we don't know, as I mentioned earlier, is what is the optimal PSA or outcome. Follow-up's a problem because regardless of treatment type, you have better than almost 60% of the prostate in our experience untreated, and the nadir is going to be important, but I don't think so much as the PSA kinetics, what that PSA does over time. So, getting close to the summary, there is emerging evidence that focal therapy will have similar disease control as the whole gland treatments. However, the morbidity may be much less. And I think we're fortunate in that the technology is ever evolving, and we have that on our side. So, in summary, focal therapy has significant promise, provided patient selection is properly performed. Ideally, these patients should be treated on study, and optimal modality clearly yet to be defined or determined which one is optimal if there is one. The salvage treatment options should still be possible for all patients, and so when you look at this is a very interesting slide by Bob Kaplan, who's a professor emeritus at Harvard Business School, and his technique of using time-driven activity-based costing. And they can look at just about any procedure, whether it's surgery or 9 weeks of radiation or 8 weeks of proton beam therapy or a single low-dose rate prostate implant. And this is called the spidergram. So obviously right here is the axis of the spidergram. These are the various things that are being measured. Cure rate, obviously important. Sexual function, GU, symptoms, urinary bother, cost of the procedure. This one would be, hospitalization on the bottom here. And then obviously time required by the patient, GI toxicity to the bowel, and then ultimate patient satisfaction. And so the red stars would be the goal, because the more area you can cover on this plot, the higher the value of the treatment. Anything that's tucked tightly in towards the axis of this spidergram, for instance, this is not a good score, this yellow dot here. And they vary, and each treatment has its pros and cons, but working through that, focal therapy does very well. And this is courtesy of Stephen Frank and MD Anderson, basically looking at spiderograms for proton therapy, conventional IMRT radiation, and then obviously low-dose rate brachytherapy. And you can see that this graph here covers the greatest volume on the spidergram. So, and those are the various parameters that they break it down for. It's an interesting concept. Keep in mind, it's ever evolving. Again, looking at the Institute for Clinical Review and Clinical and Economic Review did an analysis to look at prostate brachytherapy as compared to external beam radiation or radical prostatectomy. And their conclusion was that the total cost of brachytherapy for localized prostate cancer is less than the costs of active surveillance, radical prostatectomy, conventional IMRT radiation, or proton beam. And this was published in 2010. Brachytherapy is a high-value treatment, and obviously IMRT is costly. Not to put it down, we use it in combination therapy all the time for high-risk patients. In conclusion, the value proposition for brachy is high. This needs to be further validated on a value-based model. We need to optimize tools to communicate value, and the forefront of the healthcare reform, wherever it's going, anybody knows. There's been much talk over recent years of bundled payments that could dictate how we all treat prostate cancer, but it is yet to really hit the road in our experience. And in Stephen Frank's words, there is no greater value for the treatment of prostate cancer than brachytherapy. And with, how are we surviving with our referral base? And I think we've just really kind of about 80% of the patients we see at our clinic are self-referred from former patients. And so this has been the result of social media, patient testimonials, and we have monthly informational support meetings, community outreach through various organizations such as AARP, and corporate wellness presentations. We have, constant educational videos going for patients, and a September Cancer Awareness Month. So all these things have really kept us going here and keeping brachytherapy alive. My future predictions would be that brachytherapy will continue to be a viable treatment option. I think that as we develop more sophisticated diagnostic tools, we're going to be, that's going to dictate how we treat these patients. And so with that, I'd like to thank Dr. Crawford for inviting me to speak.
Thank you, Brian. That was a great presentation. I think you've got more experience than anybody in the country in a number of these areas, particularly in targeted therapy. A couple of questions, just in general about brachytherapy. Years ago, there was an intense uptick in the interest of brachytherapy, and it seems like that has fallen off. In light of data that actually supports its use and better outcomes, what do you attribute that to?
Well, I don't want to be negative to my colleagues, but clearly, the development of the Eurorad models and the large urology groups that have been able to, and I understand it, they're in practice, and the times have kind of dictated that they have to come together to survive today. And so they've developed their own radiation centers, and they work, and it's profitable, and the patients are. Whereas brachytherapy is very operator dependent. You really need to be doing a large volume of it to be good at it. And I also think that it doesn't reimburse real well. So there's a couple things. We did a study on the time-driven activity-based costing, and we don't have the exact number because we don't want it to further affect reimbursement, to take it down even further. But it's very cost-effective treatment. But that's what I attribute it to. I think, though, Dave, we are seeing a resurgence of brachytherapy, and not only doctors willing to use it. In fact, only, let's see, what was the study? 90% of all training programs in the country in radiation oncology do less than 12 implants a year, and that's just not adequate for
Wow.
training purposes. And that was published in the Red Journal.
Well,
So,
I think the stuff with bundled care and cost effectiveness and so forth is really going to support that again.
oh, I
Um,
definitely think so.
the
We call
data
it,
that you show, Mac Roche and others show with brachytherapy looks very good.
and probably what I didn't really emphasize too much was the recent Ascend RT study out of Canada, Jim Morris's work, where they looked at randomizing patients who were unfavorable intermediate risk or high risk patients. One arm received androgen blockade plus IMRT versus androgen blockade IMRT to the pelvis for lymph nodes and then implants. And there was a dramatic difference in disease control at 5 years. It was about 50%. So that's our first real piece of randomized prospective data, clearly demonstrating in these high risk bad cancers that any one therapy is inadequate. Any monotherapy, whether it's surgery or IMRT or implant, you really need the combined effect.
I really liked your introduction when you were discussing sort of all the options there to identify prostate cancer, mapping biopsies, MRIs, other things that we do. You do the sort of the quadrant biopsies. We do at 5 millimeter intervals, but I think our results are pretty close in identifying where the cancers are. Um, I think that's the difficult thing. And then you mentioned molecular markers, which I think are going to play a huge
Oh,
role
definitely,
in
definitely.
in this whole thing. One of the criticisms of targeted therapy is that these are patients that many of them could be candidates for active surveillance, and so this is are you really doing them any service here by doing targeted therapy? Whereas if you would take on more aggressive patients, higher Gleason scores, and have results equivalent to surgery, radiation, then it would in fact be a valuable procedure. So, what are your thoughts on that?
Well, it's interesting because we did. It was only 2% of the patients were high risk, but I think the significant percentage, as I showed, were intermediate risk. Gleason 7s,
Right.
3+4s and 4+3s, and those are real patients, and they've done really well. And I think it just comes down to patient selection. But boy, you really have to have comprehensive biopsies. You just do.
Well,
We've had one failure, and that was a contralateral failure, and that patient was easily salvaged with androgen blockade for 3 months and IMRT, and did just fine. The other thing that we're wrestling with is the volume. I hope to show in the near future that it's this PSA kinetics that we can predict based on the volume of the gland that was treated, and call it the impact PSA. What do you expect the PSA to do? And I think we're starting to see that model develop as we follow these PSAs.
one of the other things I think that might have gotten glossed over are that the complications of your biopsies, transperineal biopsies. And we have found the same thing, is that in almost 1,000 of those that we've done, that you don't get infections and sepsis
No,
with the
you just don't.
transperineal like you do transrectal. And there are areas in the world where they're sort of uh, moving towards more transperineal than transrectal, just because of the infection risk that exists, which is real.
Oh, sure. In fact, we did one yesterday. This patient had 2 ICU admissions for transrectal biopsies, and they almost died. And, the people at the University of Chicago said, we're not even going to go there. Just do a perineal mapping biopsy. So Scott Egner's been very, he recognizes the value in those biopsies.
Uh-huh. Is there anything else I should be asking you, Brian, you want to say?
No, I think it's been an interesting career. I plan to stay in it for quite some time longer, and hopefully we're publishing our third experience with these that I showed you the data on, the the mapping biopsies. It's over 3,500 patients, and we'll see.
Yeah, you've
Goes.
got a tremendous experience starting out with your 20,000 some patients you've seen at your center. That's amazing.
Yeah, yeah.
So,
Well, it's been
congratulations.
fun. It's been great working with you, Dave, and I can't thank you enough for letting me be on.
Oh, great. Thanks a lot, Brian.